Currently, in addition to apomorphine, which this patient is using as subcutaneous injection, there's another available therapy for on-demand use. In this case, with levodopa itself, it's an inhaled form of levodopa in a micro powder that is absorbed during the lungs. And like the pace of onset of apomorphine injection effect within 10 to 15 minutes, this inhaled form of levodopa also goes to work in the same time frame. And studies comparing these two drugs show a rather comparable mode of action, dopaminergic effect lasting for about an hour, usually not exacerbating dyskinesias. And in many instances, patients find these to be very reliable in terms of going to effect when used. There's no need to use them frequently for most patients, but the options of using them multiply during the day, used perhaps anticipating going off, represents a therapeutic option. Which one to use? It's sort of hard to know. Most patients haven't switched from one to the other. There haven't been head-on comparisons. The mode of delivery is different. One is an injection, the other is inhaled. There are possible side effects to each formulation in terms of how they're administered. And patients fortunately have the option of trying both of them and perhaps could make their own decision as to which one they'd like to stick with or to decide how effective it might be. I've mentioned apomorphine hydrochloride injection given subcutaneously for managing off episodes. Let me give some more details as to how this therapy can be used effectively, how it can be tested out, and whether the choice to use this is a good idea for all patients. So the typical patient who has unpredictable off time, we've talked about the different patterns of off episodes. If there's marked delay in onset of effect, particularly with that first dose of the day, that might be a candidate for using apomorphine injections to get going in the morning quickly and reliably, especially if eating food is necessary, as some patients, for example, taking insulin and having diabetes, they cannot afford the time to wait for the levodopa to kick in, given the fact that their blood sugar has to be controlled. Other examples indicate just a patient who is waking up in the middle of the night and hasn't had levodopa for many hours because they were asleep. This might be a scenario where getting rapid and reliable dopaminergic effect might be helpful. But keep in mind that apomorphine injections can be used at any time of the day. They can be used sequentially because each dose lasts only about an hour, and if the circumstances that led the first oral levodopa dose not to get absorbed effectively, it may be lasting for more than an hour to 2 hours, and it might be necessary, since the apomorphine can wear off after about an hour, to use a second dose in sequence. So what is apomorphine doing as a drug? Well, it's a fast-acting and very potent dopaminergic agent. It has morphine in its title, but it is not a narcotic. It's not habit-forming. It's not something that patients develop a tolerance to either. In animal studies, apomorphine is one of the most potent dopaminergic drugs. And one of the nice things I find about the ability of using a subcutaneous injection is that the dose the patient gets is adjustable. When it's first started, it's titrated to effect, starting with probably a suboptimal dose to make sure that a patient will not experience some of the common side effects, such as hypotension, nausea, yawning, some of the other things that can go along with other dopaminergic drugs as well. The careful adjustment of dose upwards leads to a regimen somewhere between 3 to 6 milligrams per day for the typical patient using it for dealing with off states. But a patient may have the option of taking a little bit more or a little bit less depending on how they're doing during the day. For example, a patient who has dyskinesias as a possible side effect might be in a social situation. They want to get back on, but they certainly don't want to have involuntary movements making them look sort of odd in a social setting. So that patient whose typical dose might be 4.5 milligrams might choose to dial down to 3.5 milligrams. The syringe that's used to inject is very adjustable. The patient may have a lot of familiarity with what little bit extra, a little bit less will accomplish. And so this drug is adjustable in a way that, for example, the pills are not. You either take a pill or you don't, but you can't dial down 20% less or 20% more in oral administration. Apomorphine is a drug that can also bring out dyskinesias. It can bring out dystonic spasms for those who are sensitive to too much dopaminergic effect. So it's an adjustable therapy, but usually patients get a fairly reliable absorption and a typical pattern of clinical responses once they get to know how it works. So a patient who might only be using it once a week can more or less count on the same experience as the last time, unlike the way levodopa behaves.